discuss two issues today, my dear students. The first one is on causation. Very important for us to know the cause effect of any particular inciting agent, maybe an organism, maybe a chemical, maybe a drug, for drug reactions and whatever it is, we require to know about causation. And the second one is about diagnosis, diagnostic test. That is also clinically very important. I am going to take you through only clinical epidemiology and clinical research methodology here, so that you are very familiar with what we are regularly doing, not going into too much of sort of abstract things. So let us start. So today we have moved from lot of published literature is there, and you need to critically appraise the publications, whether they are worth reading, whether they are applicable to your population, whether they are valid. What you have to do, please all of you mute the microphones. Jum's microphone can also be muted for a while, so that there is no echo from the. Okay. Otherwise, if you don't disturb it, it is fine. That is also okay. So evidence-based medicine is what is important, which is called the EBM. That is the reason we are here. We wanted to only practice evidence-based medicine based on the research. And that is what the research methodology is. Today we are the cure of the disease, ensure health, and care as humans. The days of treating a patient as a disease entity and restoring the health have gone. And we are holistic in our approach and give the dispense the health, not only cure the disease when it comes, but mostly see that the patient's population do not become unhealthy or they have ill health. So that is ensuring health, and not only ensuring health of for a particular group of people, care as an individual human being. So from a disease-centric to patient-centric to person-centric. Earlier we were talking about diseases like multiple myeloma. Then we were talking about a group of patients of multiple myeloma. Today we are talking about Mr. Venkataswamy, who is a patient of multiple myeloma. How do I manage him? That is what exactly is the patient-centric, because several interventions can be tailored as per the patient's need and patient genetic, pharmacogenetic behavior and clinical profile. So this is what is the today's world. And if we look at any particular agent, is there a causal association? What is cause? A causal agent is the one which could produce disease. That is a causal agent and the disease. No, goes without saying, the causal agent should be before the disease occurs. Then only it can be a cause. Once the disease occurs and something else strikes, then that cannot be a cause. A cause is always preceding the disease, right? So this is called the temporal relation. Temporal means time. Time relation is first the cause and then the effect. First putting the hand on the pan, hot pan, and then getting burnt is the outcome. So without putting the pan, after getting burnt, we can't say the pan has caused it. So first of all, the cause will be there, and then the disease. We move from cause to effect or cause to disease, agent to effect, and this is called a temporal relation. Prognostic factor and disease outcome. Sometimes, a particular inciting agent can be a prognostic factor in the disease outcome. For example, having less cholesterol could be a prognostic factor in a patient of multiple, myocardial infarction. The first question we ask for any patient who is admitted with myocardial infarction is he a diabetic? Because the prognosis basically depends upon the diabetes or not. So that is a prognostic factor, and the outcome also is related. That is also a causal relation. Curative effect of treatment is this particular treatment is the cause of that positive effect. Is the treatment remdesivir is the cause of a good effect in the COVID patients? Is the conventional plasma, convalescent plasma is the cause of the effect that we see? So that way, curative effect also you can say as cause effect or the treatment effect. Not only that tuberculosis, Mycobacterium tuberculosis causing tuberculosis is a cause, these are also in a way causal associations already. Adverse effects also. I have given drug A and drug B. Drug has produced this many adverse reactions compared to drug B. That again is a causal association. Question here is the association causal or casual? Causal or casual. Casual means it is not related biologically, it cannot explain. McMahon and Pugh is one of the wonderful monogram on epidemiology. He writes that in 1940s and 45s, there was an increase in the sort of people who had smoking, history of smoking, and there were also tall buildings. So how are tall buildings related to smoking? Is there any relationship that we can conceive that smoking causes tall buildings, or tall buildings are responsible for smoking? That was a very strong association between them, has been demonstrated statistically in that particular study. It only says that it is a causal association. Indirectly, you can connect, tall buildings are of affluence led to behavioral changes. Some people are more smokers and all that. But generally, there is no direct cause in that study. So this is to tell you that causal association is something which has got a relationship. How do we know that it is causal or not? We are going to examine in the presentation to come. Is the association or a factor and outcome merely due to chance, or is it biased, or is there confounding, or it is a nonsense correlation? It is called our spurious correlation. The example I gave you just now is a spurious correlation. What is confounding? I told you again, I'm telling you, confounding factor is the one which has got a bearing on the etiology as well as on the outcome, either or both. For example, when you are looking at the outcome of myocardial infarction and diabetes responsible for myocardial infarction, the confounders are hypertension, dyslipidemia, obesity, age, ethnicity. These are all the confounders which have an influence both on the diabetes and on the outcome. Bias is systematically recording higher or lower value, systematically recording an information which is away from the truth is called bias in clinical medicine or clinical research. Due to chance, that is what exactly we examine. Here, null hypothesis says the treatment A is no different from treatment B, and we reject the null hypothesis when we are confident that it can be rejected for 95% of the times. That means the p-value of 5 says the chances of they being null hypothesis being true or the treatment A and B being the same is only 5%. In fact, A is different from B from my study with 95% certainty. That is speaking about the chance. Now, is it due to bias or systematic error? We know what is systematic error. Systematic error is a weighing machine is there in my office. Let us say the true weight of the patient is 70 and systematically it gives me 65 like that. There is a systematic negative error of -5. Likewise, another patient comes 80 kilos, he registers as 75. That means there is a bias in the instrument on the negative side. Sometimes it can be on the positive side. So what is called selection bias? What is selection bias? Let us say we wanted to do a study of the mortality due to COVID. So we have taken 4 hospitals. One is Apollo Hospital in Chennai, and another hospital is James Hospital. Another is the general private practitioner's practice in Srikakulam. So there is a selection bias because people who go to the general practitioners are milder cases. People who come to James Hospital are moderately severe. People who get admitted in Apollo hospitals are people who are affluent and also they have a very severe disease. So that selection bias vitiates the comparison. The mortality in general practitioner's hand may be 1%. In GEMS maybe 10%, in Apollo it may be 30%. We can't say Apollo people are treating badly, that is why 30% of people died. Because of the selection bias, the entry criteria also are different for different institutions. And affordability also plays a part. So supposing I compare the General Hospital Chennai, compare it to a private institution in Madras, the deaths in general hospital are going to be more because everybody who cannot afford, everybody who is severe, they go to the general hospital. This is what is called the selection bias or the ascertainment bias. How do I reduce the bias there? By randomization and by blinding of the assessments, one can reduce the systematic error or the bias. The second one is the association due to chance alone. This has to be sorted out. In the previous slide, we have seen, in the previous slide, we have seen, is it due to chance? Is it due to bias? Is it due to confounding? Is it a spurious correlation? The first one we answered, how do we overcome the bias? First of all, see that the entry criteria for different groups are the same and also use randomization and blinding. Is the association due to chance alone? How do I know that? By looking at the significance test, you must be at least 95% certain that there is a difference between the groups you are comparing, and the confidence interval yesterday I told you should not include, suppose we say odds ratio of this my study is 6. The confidence interval should not include 0. If the confidence interval includes 0, then it is not worth it. It is not a significant test. Precision also can be worked out. We will see in diagnosis how precision is worked out. Is it due to confounding? What is confounding? I told you, extraneous factors affecting both the exposure and or the outcome. They can affect either exposure or outcome or both. Ensuring groups have baseline comparability. For example, I am studying an intervention in A and B, but both groups should have same age groups. Both groups should have similar gender makeup, 50%, 50%, whatever it is, and see that the baseline comparability is established. That is why whenever any research is published, they will show you one table to show that the baseline comparability is there between the study group and the comparison group. That has to be ensured and also demonstrated in the publication. The best way of ensuring baseline comparability is, of course, by randomization. Okay, and measurement, blinding measurement, both sort of the measurement in terms of the outcome, single blinded or double blinded or triple blinded, all three can be used depending upon the feasibility. So how do I reduce the bias? By a priori standardizing your instruments and also reducing the selection bias and using randomization. How do I verify whether it is chance or it is due to really happening? That is by significant test, confidence intervals, and working the precision of the measurement. Is it due to confounding? We have to match the confounders at the baseline for comparability and also use randomization and blinding for avoiding the confounding effect. Okay, now you are already told in the first day itself that there are three important types of studies apart from your descriptive studies and your case reports. We have three types of studies. One is called the case control study, the other is called the cohort study, and the other is the randomized control trial. Which one of them I use? It depends upon the question. Usually for a sort of a causal association, better a case control or cohort. Randomization is usually not feasible to look at a causal agent as an etiology of the disease. An agent as a cause of treatment you can do, but as an etiology of disease, we can't ask half of the people to have hepatitis B and another half not have hepatitis B and then follow them up for 10 years. It is not randomized, it's not possible. Similarly, I can't ask half of them to smoke and half of them not to smoke because I wanted to study. This is also not possible to have randomized design. But if I want to associate a treatment with an effect, let us say plasma, conventional plasma and without conventional plasma as a cause of improvement, then of course we can do a randomized control trial in that. So it depends on the question that we are asking. Usually etiological associations are done by cohort and case control studies. You know now by now that cohort studies, we do the relative risk and the attributable risk. In the case control studies, we go from the disease and go back at the exposure, look at the exposure. Cases of lung cancer, non-lung cancer patient, and seeing at the exposure of smoking or non-smoking is a retrospective design or case control design. Cohort study is, you have seen that biryani example. Children who ate the contaminated food, children who did not eat the contaminated food, how many of them developed diarrhea in each of the group? Look at the incidence in each of the group, exposed group and the unexposed group, and compare. By subtracting one from the other is attributable risk. By dividing one from the other, by dividing one over the other is the relative risk. This also we know in randomized control trials also you can work out a relative risk and also what is called number needed to treat, NNT. I will tell you what that is in a short way. So when you do a components of causation study, when you are reading or doing, you have to see the validity of the study, the criteria of causation, the strength of the association, the applicability to our patients. There are four areas. Is the study really trying to measure the truth? That is validity. Criteria of causation is there must be a biological explanation between the cause and the effect. If we don't have a biological explanation, we cannot say it is a causal agent. We can say it cannot be at best be a risk factor. Supposing you find an association, let us say with a particular factor and also a disease, and you cannot biologically explain how it is, then you can say it can, at best it can be a spurious association or a risk factor and not the cause. That is why for coronary artery disease, we don't have the cause for anything. We have several risk factors because the causation cannot be directly proved between one particular parameter and the disease. A multiplicity of them, a poly causation or multiple risk factors there is the one which is causing the disease. The strength of the association is measured by the relative risk or the odds ratio along with the confidence interval. Applicability to our patients, first of all, we have to see where the study is done and such patients are available to us, and whether we require to treat our patients in the same way as they treat, that we have to see from our comparing our patients to their patients. So let us say validity of the issues, validity issues are the defined groups similar in all respects except the exposure. We are studying an exposure to hepatitis B, exposure to no hepatitis B, two groups are formed, and then are they similar in all respects except the exposure? Then only they are comparable. Were the outcomes measured in the same way in all the groups? This is very important. Most often we are interested only in the study group and do a lot of sort of measurements in the study group. In the control group, we may not measure, or we do not even take note of various measurements. That is not permitted in research. We have to apply the same measurement tools both for the study group, intervention group, and for the comparison group or the control group. Were the patients and researchers blinded in ascertaining the outcome? That improves the validity, of course. Blinding is not always possible. Suppose, let us say, treatment A is surgery and treatment A is coronary artery bypass graft. Treatment B is stenting of the artery. We cannot blind the patient from the surgery, isn't it? So blinding is not always possible. Okay. So bariatric surgery versus a sort of drug for obesity. Bariatric surgery will be known to the patient that he underwent the procedure. So you can't blind always. In such cases, the assessments can at least be blinded. Was the follow-up period adequately long and complete to get a good number of outcome? What is this? For example, you have started a study on a vaccine and wanted to see whether tuberculosis occurs in the vaccinated group less compared to the not vaccinated. So you give BCG today, you can't expect the disease to occur in 3 months or 4 months. You can't compare. The follow-up will be around 15 years, 20 years. The famous BCG trial has tried BCG versus placebo for 25 long years to conclude whether it works or not. So the adequate length of follow-up is also required depending on the disease. In some diseases, supposing I am giving iron, one salt of iron, and another thing is I am giving hemoglobin preparation. As such, comparing for improvement in anemia, the duration can be 6 weeks or 8 weeks. It need not be very long. So depending upon your question, the duration can be very long or can be very short also. So if it is very long, you plan a case control study. If it is shorter, you plan a cohort study or a randomized study. So there is one by name Bradford is a beautiful epidemiologist and researcher, medical researcher, and he has certain sets of causes of criteria for the causation. What are they? So you have to remember when you are talking about cause, does the exposure precede the outcome? This is what I was telling. The exposure or the inciting agent should occur before, and then somebody should develop the disease later. For example, somebody should have got contact with a COVID patient, and then later on he develops COVID. Then we can say, okay, this contact has resulted in that. That is what is called the temporality. Is there temporality? Okay, that is the time relationship is appropriate. With exposure first and then the outcome. What is the strength of the association? This is measured by p-value, which should be at least 0.5 or 5% of the 5% only is the error, 95% strength in that conclusion, and confidence interval should not include 0. So when you say relative risk of 2, if the relative risk confidence interval includes 0, then it is not going to be any useful study. Is there a dose-response relationship? What is this? So I have tried, let us say, a drug. Mild patients did better compared to moderate, compared to severe. There is a dose-response relationship. Smokers who smoked 5 cigarettes a day compared to 10 cigarettes, compared to 20 cigarettes, there is a dose-response relationship. You have given 5 milligrams, or you got some effect, give 10 milligrams, you have a better effect. This is called dose titration studies and dose response relationships also. Then is the association specific to this particular agent? Can it be caused by so many things? Then I cannot say this is the causal agent. For example, diabetes. We know several people develop myocardial infarction without diabetes. Likewise, several people develop infarction without hypertension. So we cannot say that this is the cause. We can only say this is a very strong risk factor in such a case. Is there evidence of reversal when the exposure is removed? This should be very well documented. For example, we very well know that the COPD changes until some stage are reversible once you stop smoking. Maybe on a 2 or 3 year period, if you stop smoking, the changes are reversible. Likewise, the progression to renal disease is reversible provided you control the microalbuminuria very early. So this reversibility also has to be established. Is there consistency of the results across similar studies? I found an association between this risk factor and this disease. Are there other reports showing a similar trend? That is very important to establish for causation. Does the association make a biological sense? Means, is there biologically can explain this cause as producing that disease? The tall buildings in New York and smoking has no biological connection. Likewise, we may find several coincidental observations you will be seeing in your WhatsApp about sort of COVID. And unless you have a biological sense, you cannot really think them as causal. Okay, they may be casual. Okay, is there a coherence and analogy of the exposure and outcome? Means, in general population, those who are exposed are getting disease, those who are not exposed are not getting disease, then there is a beautiful coherence. So these are the 8 criteria of Bradford. Number 1, temporality. Number 2, strength of the association as measured by your p-value and confidence interval. Number 3, dose-response relationship. Number 4, is it specific to this agent or many agents are causing? Or is there a reversal after exposure? Number 5. Number 6, is there consistency across similar studies in the literature? And number 7, does the association make any biological sense? Is there a biological, biochemical, or pathophysiological explanation that can offer? So now we are saying cytokine storm. We must have a biological explanation how cytokine storm can produce this amount of morbidity and mortality. Unless we have that biological basis, we cannot blame cytokine storm as this. And we have seen in our COVID lectures in the pathogenesis, yes, cytokine storm has a biological basis because it produces microthrombi in the lung circulation. It produces exudation into the lungs and produces ARDS. There is a biological sense there. That is what is meant by biological sense. Is there a coherence and analogy between the exposure and the outcome? So these are the Bradford Hills criteria. The article I am going to circulate to you now for review, you have to apply these criteria and the questionnaire asks you to do that and then come out with an answer whether it is working or not. How do I measure? I measure in case of a prospective study or a randomized control trial, cohort study and randomized control trial, I do relative risk calculation. What is the relative risk? Incidence in the exposed group divided by the incidence in the unexposed group is a relative risk. Attributable risk, incidence in the exposed group minus the incidence in the unexposed group is the attributable risk. What is odds ratio? The odds of having the disease, odds of having the exposure in the disease compared to the odds of not having. AD by BC is the formula there. Number needed to harm in case of adverse reactions and causation of disease. Number needed to treat in case of therapeutic things. This we will go a little detail there. I told you, if you divide 1 by the attributable risk, that gives you the NNT. If my attributable risk is, let us say, 0.1, and I divide 1 by 0.1, that means number needed to treat is 10 people need to be treated to get the benefit. If attributable risk is 0.2, 1 divided by 0.2 is I have to treat at least 5 patients to get this benefit. If the attributable risk is actually 1, that means 1 by 1. If I treat 1 patient, sure, he is going to improve. If let us say if it is 0.1, then I need to treat 100 patients to get the benefit. So this is what is called the NNT. What is the precision in terms of the confidence intervals? This is the relative risk, attributable risk, and the number needed to treat, and also the odds ratio. Then you have to put the confidence intervals to give you the precision. Confidence interval should not include 0. If they include 0, it is not precise. You have to either repeat the study or then look at why it is not giving the confidence interval within that 0 range. Maybe you need to increase the number of patients, or you have to observe for longer period, whatever may be the reason. So this is about the strength of association. Now, are the study subjects significantly different from our patients? Supposing we are studying, looking at a report, which the study subjects are totally different from them. How is it important? For example, Spain and the European countries reported a mortality in the hospitals to the tune of 20%. Okay, 20%. None of our case fatalities were there so high. The case fatality, the COVID mortality in Spain initially was 15-20%, and we are not having that much. What is the reason? Their population is very aged, 80 plus, and we have very few people who are above 80. So that is the study subjects are significantly different. That is why that conclusion cannot be grafted here. They have old age homes where if one old person gets disease, COVID, it is easily spreading to all others in 80 plus people. Whereas we don't have so many old age homes, and there is no cluster of old people available in one particular place in our country in general. There are a few here and there old age homes, but in general, our old people are either confined to their homes or they're living with 1 or 2 family members of theirs. So that is what exactly is are my patients similar to the patients that I am looking at the report. What is the individual potential risk and benefit to our patients? Supposing, okay, I have read the study. Can I use this here? What is the risk for our people? And what is the benefit to our patients? We have to think whether we can generalize the results to our patients. What are our patients' concerns and their expectations? Let us say an intervention is there. We know that, circumcision prevents a lot of diseases related to sexual contact. But Hindus in general, they don't undergo circumcision. We can't ask them to use that as an intervention. So what is our patient's concern? Will they really follow if I say this? Are there any alternative treatments available which are cheaper, which are easily available? Suppose a drug is costing 5,000 rupees per dose. There is another cheaper alternative, more or less similar to that, which costs around 10 rupees. Then a country like ours should go in for an affordable treatment rather than a little superior sophisticated treatment. So these are some of the applicability issues related to that. And this exactly we have done that A by B, B, C, D. Here again, look at cases and controls. Cases are lung cancer cases, controls are no lung cancer. Exposure is the smoking there. So A is the number of people who had smoking among cancers. B is the number of smokers among controls. C is the number of people who are non-smokers among controls. And D is the number of people who are non-smokers among the controls. C is among the cases, D among the controls. Totals are A plus C, B plus D here. On the horizontally, A plus B, C plus D. So let us turn them into numbers for easy understandability. 240 patients studied, 110 were smoking, 130 were not smoking. Among the 110, 80 were smoking and also had the lung cancer. 40 were non-smokers among the lung cancer. 30 of the smokers are belonging to the control group. 90 of the smokers are belonging to the non-smokers are belonging to the control group. So this form table called the 2 by 2 table is formed. The formula is A by C divided by B by C, which is equal to AD by BC. You have done this calculation and all of you have given me the correct answers. I am happy about it. I am just recapitulating that. Likewise, you can just imagine when the odds ratio will be infinity. It can vary from 0 to infinity. Let us say none of the lung cancer patients is a non-smoker and none of the control fellow smoked, which is the universe ideal situation. That can never happen. So out of the 120 lung cancer smokers, everybody is having lung cancer. Out of 120 controls, everybody is a non-smoker. In such a scenario, the risk will be infinite. Just work out the same thing, AD by BC, the cross multiplication 1200 in 1200 into 1200, 14,400 divided by 0 into 0, because it becomes infinity. This is the hypothetical situation. Likewise, it can vary anywhere between 0 to infinity, at which stage I will say it is association. Anything more than 3, odds ratio is powerful enough. The more it goes towards 10, 12, the odds ratio is really strong. Okay, this is a prospective study where A plus B people are exposed to the treatment, let us say remdesivir, and A plus C plus D are not given remdesivir. Out of them, A had the disease cured, and then B did not have the disease. So likewise, ABCD tables. Remember here, capital letters are written. So the incidence in the exposed group is A by A plus B. The incidence in the unexposed group is C among C plus D individuals. A among total of A plus D individuals got the disease. C among C plus D individuals did not have the disease. Okay. The C among C plus D had the disease among the unexposed. So a ratio between them, A by A plus B divided by C plus D, is equal to relative risk. This, when you turn into numbers, so here 100 patients have children have taken residing in the hostel. 23 people who took biryani had diarrhea. Out of 33 children who took biryani, 23 had diarrhea. 23 by 33 is the incidence of diarrhea in the biryani group. Likewise, 7 out of 67 is the incidence of diarrhea in the non-biryani group. A ratio of them is what is called the relative risk, 6.67. And attributable risk is one subtracted from the other. So when can this become maximum? Let us say everybody who took the biryani had the diarrhea, and everybody who did not take the biryani did not have the diarrhea. So the A33, 033, 067, that is a scenario where there is a 100% relationship with the exposure and this one. And it can go anywhere between minimum 0 to maximum infinity. Again, a relative risk of 2 or 2.5 or 3 itself is good enough. Unlike odds ratio, we require it to be very much higher, whereas the relative risk of more than 1.5 or 2 or 3 is quite good enough to say that there is association. Usually it is difficult to find relative risks of 10, 20 or like that. We will not find that. So this is the thing that you have to keep in mind. A relative risk of 2 or 2.5, of course, the confidence interval not including 0. Okay, this is the attributable risk. I told you, the one subtracting the other. So this is understandable. And number needed to treat is 1 divided by the absolute attributable risk. Okay, if the relative risk is there is a way of converting relative risk into odds ratio. Relative risk of 0.8, odds ratio 4, 0.67 it is 2, relative risk of 0.5 is equal to odds ratio of 1, relative risk of 0.2 is equal to 0.25, and 1 is to 0.11. Don't ask me how you do it. There's a little bit of calculation is involved, but just remember that relative risk and odds ratio can be statistically related. Okay. So how do I get that? OR is equal to relative risk divided by 1 minus relative risk. So how do I get it? OR is equal to relative risk divided by 1 minus relative risk. Or relative risk is equal to OR divided by 1 plus OR. So this simple formula is there, but don't worry about that. And I'm going to close this presentation now, 45 minutes, and I'm going to leave you with the thing. So here you see absolute relative risk, you can understand from this. So there is a green bar there, tall green bar, and a lighter green color, blue color and green color. So the blue color bar and the tall green bar, look at the tall ones. The difference is the absolute risk reduction. Whereas when you do the relative risk, that the blue bar is the placebo and the black bar, green bar, small green bar is the treatment, then the risk reduction will be a ratio. That is why you don't see a big jump. Whereas when you have an absolute risk, you have a big jump there. So it's worth calculating both relative risk as well as the absolute risk. Okay. number needed to treat, I told you that number of persons would have to receive an intervention for one patient to get the benefit. If the disease has a mortality of 100% without treatment, and if the treatment reduces mortality by 50%, how many people would you need to treat to prevent one death? For example, the relative risk is 100 divided by 50. Mortality rate is 50%. That is 2. The relative risk is 2. That is, if without the disease, 50 people are dying, with the disease 100 people are dying, so the relative risk is